I also noticed in a few of the other presentations in other sessions that people were putting up disclaimers. So my disclaimer is I'm a statistician and I'm going to have a lot of graphs and I'm even going to have one or two equations. So I apologise in advance in my presentation. Before I talk about malaria, why have I said, when I have colleagues or friends have a child, become a parent for the first time, I always tell them that being a parent, it's sort of 2 steps forward and 1 step back. So you just get the baby and they're in this nice sleeping pattern, and then all of a sudden, 1 step back because they start to teeth. And the treatment of malaria over the last 100 years is a bit of a similar story. Every time we seem to have a new drug and we're making great progress, lo and behold, the parasite becomes clever again and has resistance, and we go 1 step back and we have to look at new ways. And that's about the story I'm going to tell with what's going on with malaria today. Okay, so Stephen's already covered about control and elimination and what's the current policy and how do we do this. So we have preventative things like bed nets, indoor residual spraying with insecticide, and also mostly in Africa there's policy where we give pregnant women a treatment as a prophylaxis in their 2nd or 3rd trimesters. Another key policy thing is actually to treat people promptly with effective anti-malarials. And that's pretty much where we're at today and WHO policy on how to control and eliminate malaria. Future interventions are looking at often what's considered controversial things like a mass drug administration. That's when we administer everyone a drug even though they might not have the disease, and we always have that controversy as well with vaccines. We've also got vaccines along the way, and this little timeline from 2015 onwards is still that the vaccines having to go through, getting through the regulatory authorities and all that. But I think as James will speak after me, it has very low efficacy still, so there's the controversy of should we even introduce a vaccine that has such low efficacy. So here's our little 2 steps forward, 1 step back over up to the mid-90s, where we would introduce drugs. So in the 1600s, quinine did all right for quite a while, but all the other drugs since, you can see that even as just they're introduced in the same year, we see resistance develop. And on the right-hand side is a graph of the y-axis is cure rates and on the x-axis is year. And this is from the Shocklow Malaria Research Unit, which has been doing we just had the 30-year reunion in December, following malaria treatments and their cure rates over time. And when I arrived in the mid-90s, we were in pretty dire straits. The current therapies like mefloquine were at efficacy of about 60%, and we just started off then with some new drugs. And so we went forward again, and we were saved by the artemisinin. And these drugs were incredible. In fact, the researchers that found these novel drugs were awarded the Nobel Prize in just the last year or so. And why were they so effective? Well, their action is rapid and potent. They kill more parasites in the first couple of days than any other anti-malarial available. They also have the properties that they can reduce transmission of the infection carrying on to another person. Unfortunately, the cons, though, is the pharmacokinetics of the drug is such that if you took one of these tablets today, it would only be in your body for about 6 to 8 hours. So it means we have to keep repeatedly dosing people daily and up to 7 days or more to treat an infection. So we actually have to give it with another partner drug, less effective anti-malarial. And you might wonder, why is it so effective? Well, the life cycle of the parasite in the red blood cell lasts 48 hours, and the artemisinins kill nearly all that stage of ages for that parasite. And how effective it's been is being demonstrated in this landmark paper in The Lancet in 2004. So on the right-hand side here is a forest plot of a meta-analysis of many studies across Africa and Asia where they compared current therapies with giving that drug plus the artemisinin derivative. And you can see here that the reduction in failures was enormous, even much more than halving of them. So it really was an incredible collection of studies that show that the way forward was these artemisinin combination therapies. So the artemisinin derivative plus a partner drug, which often will be mefloquine, sulfadoxine, pyrimethamine, lumefantrine, and piperacin. And since that 2004 landmark paper and research that was funded mostly by the WHO, the uptake of artemisinin combination therapies has been quite substantial. In fact, we're now seeing every year over 400 million treatments are administered every year. And with that has benefited enormous reductions in malaria mortality and also morbidity. So on the right-hand side is the cases that we have seen averted in Africa. Now you can see preventive things like bed nets, which is the green, is still the huge player there in Africa, but the ACTs, the pink, are also having a huge impact. And that's even considering that we're only reaching 20% of the population with these drugs. So imagine what we could achieve if everyone had access to these. And that's, again, the important thing. It's not just the science, but it's about that community engagement and funding and changing policy at national level to get those treatments out there. But we went 2 steps forward, we then went 1 step back. And so what happened in about the last 6 to 7 years is that we saw artemisinin resistance develop. First, it was close to the Thai-Cambodian border, but as you can see here, it's now spread across Southeast Asia. And so here in these little pie charts, the little red bit is where we're seeing slower delays in clearing those parasites. And luckily, it hasn't yet reached Africa, but I think it's not far away. This is from the Tracking Resistance Artemisinin study. So where to now? We went forward, now we're back. Where do we go now before this disease is untreatable in the Asia-Pacific region? Well, you might say, well, where's the next drug coming along with the pipeline? Well, unfortunately, that will probably be about 4 years away. These things take a long process in terms of going from phase 1 through to phase 3 studies and then getting registered with the EMA or the FDA. So we need to come up with better ways to give the current drugs that we've got available. They still work, they just don't work as well. So we have to think up new dosing schemes. Maybe instead of 2 drugs, we need to go 3 drugs. Maybe instead of 3 days treatment, we need to give it 4 days or twice daily. And one really sort of cheap way is to use statistical and mathematical modelling to just have a look at what approaches are available to then be a decision tool for what sort of clinical trials we might want to consider when we're thinking about changing our therapies. And so what we do is we develop these within-host malaria models that link the concentration of the drug to the actual parasite burden. And so here's my only equations. So we first of all try to predict what the parasite burden will be in an individual if they take some treatment regimen. So we have a series of equations that describe how the parasite develops within the red blood cells within an individual, and also we put the drug X on to kill those parasites. So if you think of these plots with the red and orange and yellow, on the left-hand side would be a distribution of the parasites in your blood cells before you have treatment, and on the right-hand side is after treatment. So it's starting to kill different ages of the parasite. And from those, we can then derive plots that plot how your parasite count will change over time according to different drugs you give and their pharmacokinetic profiles. Once we've predicted this for an individual, we can add some stochastic nature to it and now start to predict for populations of individuals and work out what would be a proportion of cure in, say, 100 or 1,000 patients. and look to see how these proportion of cures would change as the drugs start to become less effective. So in the right-hand side here, I've got concentrations where these two drugs have 50% effect, and it's increasing a lot. And on my y-axis are my proportion of cured of my hypothetical simulated patients. And these models are informed, of course, from data and our knowledge of the biology of the the parasite and how it relates to its action on the drug. And we've done some progress here in improving the treatment of severe malaria for children by using this modelling and validating it with data to be able to change guidelines, which we did in the most recent WHO guidelines for the treatment of malaria. So we can even tailor it not just to a population, but to vulnerable populations like children and pregnant women. We also have to think as we move towards elimination, but also have this counteracting thing of drug resistance, that what is actually going to happen in terms of the host immunity. Because when people are exposed to malaria and multiple infections, they acquire their own immunity, and this immunity actually assists the anti-malarial drug in killing the parasites. But from this work that Freya Folks Group has led, what they've found is in areas where artemisinin resistance is emerging, we're actually seeing immunity the lowest. So even though the drugs now are struggling because we've got resistant parasites, they have to even work better because we don't have people with naturally acquired immunity to be effective in helping out the drug clear those parasites. So on the right-hand side here, the graph, the black and red lines are markers of resistance in terms of parasite clearance half-life, or the Calch13 genotype mutation marker, and the blue triangles are measures of immunity biomarkers and how that's changing. And this has been measured across different areas in Asia that have differing levels of resistance. So as we move towards elimination, we have to always keep in the back of our minds that naturally acquired immunity is going to be less, and therefore there's going to be more pressure on the drugs. So not just the resistance, but elimination reduces immunity. So as well as optimizing therapies, so we give it a better way so that the drug maybe prolongs its lifespan for a few more years until those new drugs become available, maybe there's another way we can accelerate elimination, because we're in a bit of a worried case if we end up with untreatable malaria before those new drugs become available. So one thing is this mass drug administration. And as I said earlier, it's a bit controversial because you're treating everyone and maybe not all of them will have malaria. And why do we want to consider mass drug administration? Why don't we just give drugs to the people that turn up the clinic sick and have malaria? The problem is that there's a lot of people in areas that have malaria infection but don't feel sick enough to go along to the clinic. And also, the tools that we currently use to detect malaria miss a lot of cases of malaria. And so this is my iceberg picture. So by using microscopy, which is what we use mostly out in the field, we're only seeing the tip of the infections. And actually, if we can do things like large volume PCR, we're going to pick up a lot more of these submicroscopic infections. And this has just been shown in areas where they were able to do these large volume PCR. You can see here that they capture most of the distribution, but with the microscopy, you're probably only seeing half or less of the infections. So on the Thailand-Myanmar border in eastern Myanmar, the Shoklo Malaria Research Unit recently got funding from the Bill and Melinda Gates Foundation, I think the Global Fund and the Wellcome Trust, to go across and set up malaria posts and intervene and do mass drug administration. First of all, they did a pilot study in just 4 villages to show that it was acceptable and feasible. And then they launched it more into 50 villages that they identified as hot spots. So there was a lot of this sort of submicroscopic infections there. And I think it's pretty telling, this figure, that you can see the incidence of falciparum malaria has dropped incredibly after the mass drug administration. Now, this is still just a study. This is not a policy throughout the whole of Myanmar. This is just being funded and led by a research group. But it is, as Stephen said, it's in one of those border areas, and they're the hard-to-reach areas and the areas where we'll probably see the biggest effects. So I'd just like to conclude, in the last 10 years, it really has been a public health triumph in malaria control and elimination, and we have gone forward, and that's been thanks to the bed nets and these artemisinin-based combination therapies. But it could all be undone. We have to eliminate falciparum malaria in the Asia-Pacific region before it is untreatable, and that's because we are seeing more and more artemisinin resistance spread, and just in the last few months we're now seeing resistance to one of the partner drugs given with that, which is piperaquine in Cambodia. So we have to keep thinking, what is the better way to give these treatments so that we can cure people? Like I said before, do we extend it out to 4 days? Do we give a further partner drug? But obviously in comes their costs and acceptability, so there's a lot to be done there. And should we just be going in more and treating everyone with mass drug administration, or tailoring it just to those hotspot areas and those border areas? Thank you very much.